Good afternoon. And I'll be presenting this on behalf of my colleagues and also in a way bringing forward some of the insights from Dr. Peter Cheretich, who's the current interim director of the National AIDS and STD Control Program in Kenya, because they are the ones who are reviewing guidelines, changing the guidelines, and I have a few slides from him to share. So just to tell you about the original study that we began called the HIV and Pregnancy Intention Study, HAPPY study. This was written back in 2007 in response to a specific RFA that wanted to get a series of studies looking at the interplay basically between reproductive goals and HIV risk. So what we proposed was to come up with a community enrolled cohort in Western Kenya, which is basically the epicenter for the epidemic in Kenya, and follow forward heterosexual dyads, looking at HIV incidence, pregnancy, intent, and so forth. And our original goal was to enroll initially 4,800 couples and follow forward in time 2,400 of those couples. We originally powered our calculations thinking that we would enroll 960 HIV discordant pairs. And I'll talk a little bit more about that. The other aim then was to really look at other contraceptives, sexual risk behaviors, individual and couple related expectations, beliefs and behaviors, and then to sort of come up with a model that would be provided to stakeholders and implementers in Kenya to advise any ways to improve integrated programs of delivery for HIV and reproductive family planning, contraception, and so forth. So what we've done is we utilize spatial sampling in order to enroll this cohort, and I'll tell you a bit more about that in a minute. We're using handheld PDAs to do that sampling, geomapping, and then a self-administered ACASI survey. The enrollment criteria are heterosexual couples who are sexually active, living together, planning to be in the study area for sort of the duration, because our follow-up period was to be 24 months of follow-up. In Kenya, the age of majority of a young woman, if she's married, is 15 and above. And then we would institute in the home rapid HIV testing of the couple and do urine testing of the woman. And we also did some qualitative work before and during this cohort period. And just to note the key findings from some of the original formative work of the qualitative, we did free listing and pile sorting, and then where you have people basically rank, name and rank the themes that are of importance to them in these domains of reproductive health and HIV. And then we looked to see, whether those rankings were different by subgroups, such as males versus females. Bottom line, basically, there's a big discrepancy between how many children men want and how many children the women want. So family planning services are very much perceived to be a women's realm, and women do use them, but in secret, because there is really this discrepancy there. Stigma is still quite prevalent for HIV, and non-disclosure of HIV status is still quite common. Multiple concurrent partnerships are sort of frowned upon officially, and a sort of that's seen as a driver of the epidemic. On the other hand, this is a part of the country where many of the folks actually do engage in polygamy, and that's a kind of a cultural norm, including widow inheritance and other practices. So we've also done interviews with the couples and had focus groups that have been matched and homogeneous by serostatus. So we'll be able to look at trends in ideas like treatment as prevention when we repeat those focus groups a year hence. So this is taking place in Nyanza province in Nyando district, and this is actually, as I said, really where the preponderance of HIV is. Highest noted prevalences there in the west by the lake. And there are quite a number of other issues going on, high unintended pregnancy rates, higher than the rest of the country, including higher prevalence amongst pregnant young women than non-pregnant young women. So rather than doing sort of a two-stage cluster sampling method based on kind of old census data, we decided to use this random GPS sampling method. You create a sampling frame, and you choose longitude and latitude points. We did it population proportionate, so there's a known probability of selection. So it essentially is a random sample choosing on the GPS site first. And we're doing this in the community, so we wanted to sort of avoid some of those biases around clinic-enrolled research cohorts where the couples come to you. Here we're going out to the community and randomly selecting households and letting them know about the study and enrolling them if they agree to participate. We mapped the service sites, including non-traditional services like traditional birth attendants and herbalists and abortion providers, which is illegal in Kenya. So we came up with a sampling frame of 10,000 household GPS points, just to give you an idea of what that looks like in a little more detail. Our field staff, who are pretty hardy, go out to that point, even if it's in the middle of a rice paddy, and then they have an algorithm to locate the closest household if the selected point isn't on a household itself. They enroll the couple, consent and enroll. The couple has to agree to receiving HIV test results together. Before we do the HIV testing, we have them answer behavioral questions on the ACASI, audio narrated in English and Deluo. And then we do the Government of Kenya standard home-based VCT. We do the pregnancy testing, and we make appropriate referrals and provide condoms. So just to quickly run through where we are at this point, we've now enrolled 3260 couples. There's actually a few more individuals than that because there are some men who have polygamous relationships. And the distribution, the discordant couples has actually been lower proportion than we expected. 14%. We had originally thought there would be closer to 20% of all enrolled couples would be discordant. So out of the almost 10,000 points, we're almost done now with our sampling frame. We have enrolled this number. This is the, it's kind of, we're seeing equal prevalence, male and female. And at enrollment, 2% of all women were both HIV positive and pregnant. So there's a lot of need out there. And 1 in 4 women were planning to get pregnant in the near term. Protective behaviors are really pretty low. Not a lot of circumcision reported by the men in the cohort. Condom use is low. And there do seem to be some associations with HIV prevalence and increasing number of pregnancies, for example. And so there's sort of an array of factors that we're starting to see having some association with some of the key outcomes, such as condom use, pregnancy intent, actual pregnancy, and then discordance. And these factors are things that we believe we can begin to start looking at as a way to sort of target the higher need, higher risk couples. So our protocol was to enroll a certain number of couples and then follow forward all the discordant dyads, all the concordant positive dyads, and then take about 1 in 3 of the concordant negatives, knowing that that would be by far and away the largest grouping, and we couldn't follow them all. So that's essentially what our follow forward has been looking like, about 3,200 couples being followed forward. We had 90% retention at the first 6-month follow-up, and they're all in different stages now of their 12 and 18-month follow-up. We have seen 24 seroconversions over this time, equally divided between men and women, and really almost an order of magnitude higher incidence rate among the discordants, as you might expect. And also that of the 12 women who seroconverted, 2/3 were women who wanted to become pregnant, intended to become pregnant. So again, looking at that interplay. This just shows you the distribution as we're still going out and doing the follow-up sessions, so the numbers will shift a bit. And we're going to be looking at, we're getting from the Census Bureau age-specific mortality rates for this area of Kenya, so that these quick proportions of the individuals who have died during the follow-up period, if that, the numbers may change a bit, we're going to really tie it more to look at, to compare against age-specific mortality in general for adults. But ironically, if these relative proportions hold, it may be the case that being HIV positive, one or both of you being HIV positive, might be a proxy or indicator of actually having more consistent care. And you can see that actually the concordant negative people maybe have a higher mortality occurrence because they're not in care of some kind. So at this point in time, what we're seeing is that there clearly is a high levels of discordance, high desire for pregnancy, and whether intended or unintended, high occurrences of pregnancy. and it really stresses the importance of integrating the services for HIV and family planning, particularly higher risk couples. Discordant couples, discordant partnerships obviously being a risky group, and so as we were moving along with this, new guideline drafts were circulated in Kenya that at one point at least suggested that discordant couples might be offered, for the index partner would be offered ART irrespective of CD4. So now coming to the slides that Dr. Peter Cherotich has shared with me, here's where Kenya seems to be now, and the guidelines are circulating now. Treatment initiation has been bumped up, threshold from 200 to 350. The first target group is going to be option B plus pregnant women for the reasons listed and as described earlier by some of our colleagues. That they really, the national program felt that implementing option B plus for pregnant women certainly makes the most sense. The infrastructure is there, and they can track some of the issues that might devolve from this and be able to problem solve along the way. The next target group is patients with TB, again, irrespective of CD4, and this is sort of supposed to be happening anyway, but it's been a bit haphazard. The next group after that will be sex workers, and this goes to some of the questions that have been debated here about do you target higher transmission risk groups or not? And then only after that would discordant couples actually be offered ART irrespective of CD4. However, there's an opportunity to do that on a pilot basis. And then after that would be injecting drug users, and funding and resources allowing, potentially everyone, would be the phase 3. Tracking impact, and again, WHO metrics will be looking at this, but the thinking is to use viral load using dry blood spot data capture, which is easier to manage. Still have to deal with lab network issues. So where we are at this point is we've talked with our project officer. It turns out because we didn't have as many discordant couples as we thought, even though kind of disappointingly, in 1 in 4 households in this part of the country, one or both of the partners are HIV positive. So it's really quite a high prevalence. Nonetheless, we wouldn't really be powered to see one of our aims around pregnancy and HIV incidence association as such. So we're going to finish our enrollment when we hit the 10,000 spatial points that we originally planned. We're going to keep going back to the concordant negative and concordant positive couples. But for those who are discordant, we're going to go back to them with a little bit of an enhanced information when we return for the protocol study visits, which is to talk about the new treatment threshold, option B for pregnant women, and then we'll see if there are other elements that we can layer in. And again, stress all the appropriate referrals and do a bit more maybe with identifying barriers and facilitators to make sure they get to those services. We'd then like to seek funding and put together a proposal to go back to our discordant couples, not lose that infrastructure, not lose access to them because there aren't that many community enrolled discordant couple cohorts, and offer them perhaps more of an intervention that would be essentially looking at acceptability and cost of heterosexual couples treatment as prevention package that would allow us to use the spatial sampling, the HIV and pregnancy testing, and then possibly consider something innovative, perhaps by adding nurses to the field staff, basically a home-based initiation potentially for medications as a way to facilitate treatment and then linkage for ongoing care to the HIV clinics. So just want to recognize all of our hardworking field staff and ICHD for the funding.